I'm very pleased to introduce our professor for grand rounds this morning. Is Dr. Amy Krambeck, who's a professor of urology at Northwestern Medical in Chicago, Illinois. Her urology residency was completed at the Mayo Clinic in Rochester, Minnesota in 2008. Subsequently, from 2008 to 2009, she participated in an endourology fellowship at the Methodist Institute for Kidney Stone Research in Indianapolis, Indiana. From 2009 to 2016, she worked as an endourologist in the Mayo Clinic Department of Urology, then joined the staff at Indiana University in 2016, where she ran the Benign Urologic Diseases Division until 2020. Dr. Krambeck specializes in the surgical and medical treatment of stone disease and benign prostatic hyperplasia. Her research interests include the pathogenesis of stone disease and the treatment of urolithiasis during pregnancy and economics of BPH surgery. This morning, Dr. Krambeck will be discussing the Holmium laser enucleation of the prostate for BPH.
So we will be talking about Holmium laser enucleation of the prostate. My disclosures have not changed since yesterday. I am a consultant for Boston Scientific and Luminous, and I do talk about Luminous and their laser later in the talk. These are our learning objectives. Really, I just want you to understand that the long-term and short-term benefits of HoLEP, as well as the potential complications, and then the improvements that have been made to make it a safer surgery. So I'm fortunate that you have someone at your institution that's doing HoLEP, so you have an understanding of the procedure. But basically what we have done is we've taken a suprapubic prostatectomy and turned it into a natural orifice surgery. So we're doing the exact same procedure, just through the urethra without any incisions. And HoLEP has been around for an extremely long time. Most people think it's relatively new because it's gained in popularity lately, but it's actually been around since the late 90s. So it started with Holmium laser ablation of the prostate in 1996, and they were using it to ablate tissue just like a PVP. And then it transitioned to resection. They realized that the laser had properties where you could actually cut the tissue. So a resection very similar to a TURP was performed in 1997. And then in 1998, they realized that they could get into the same plane that you did a suprapubic prostatectomy in. And so a morcellator was developed and full lobe enucleation was performed in New Zealand by Peter Gilling. So HoLEP has actually been around since the late 90s. And HoLEP can be performed with any size sheath. Usually for the big prostates, I will use a 28 French scope because this is the best flow and you are trying to work efficiently and get this large prostate out. But you can do the procedure with a scope as small as 22 French. For smaller prostates, I'll use a 24 French Wolf scope, which is nice because you don't have to change out for morcellation. So varying sizes of scopes can be used. And this is the first morcellator developed, the VersaCut by Luminous. It's definitely a tank. It doesn't malfunction. It's very reliable, but it's not very efficient. Most people use the Wolf morcellator. You put the morcellator through an offset nephroscope, which goes through an outer sheath on the scope. And when you morcellate, you want to make sure that the bladder is fully distended. I think when people think about HoLEP, they worry so much about morcellator bladder injuries, and it's really not that common. If you have two inflows on the scope and only use the morcellator as your outflow, then you will not have a bladder injury. You keep excellent visualization, keep the tissue in the middle of the bladder, and morcellate safely. Bladder injuries really shouldn't occur outside the learning curve. And then this is what the end product looks like. It's just we call it ham salad in my OR. I don't know what you guys call it there, but it has a consistency of ground up meat. So I know that you do a lot of end block there. I do HoLEP slightly different. So I let the prostate dictate to me how we want to do this. So if there's no median lobe, I make one incision at 6 o'clock. If there's a small median lobe, I'll make it on at the 5 or the 7 o'clock position. And if there is a sizable median lobe at all, I'll do a 2-cut incision at 5 and 7 o'clock. And when I make these cuts, this is an area that you can be actually quite quick in. So this is about the only time I will actually touch the tissue with the laser fiber. So I will make a cut from the bladder neck to the viru all the way down to the capsule. And I can really, especially in bigger prostates, I can really bury the fiber to efficiently cut down to the capsule. And I can tell the difference between capsule and adenoma because the adenoma has a fluffier reaction to the laser that almost looks like cotton as it interacts with the laser, as opposed to the capsule, which is smooth and glistening, and it won't fluff up. So when you're doing a HoLEP, you're actually looking at how the tissue reacts to your laser fiber. Once I make those 2 cuts, then I will peel up the median lobe, and I do an upside down U incision, just connecting my 2 cuts and releasing the urothelium. And this particular prostate is over 300 grams, so it's an extremely large prostate. But most prostates have a nice defined median lobe, so it's very easy to develop the plane. And again, I'm not touching the tissue with the laser fiber. I'm allowing the acoustics of the laser to do my dissection, and a little bit of the heat that's delivered controls the bleeding. The tissue is now tented up over the top of the scope, so I'm doing the traction, counter traction to expose the plane that I need to enucleate. And median lobe enucleation is great for the learners. So the residents all start with, and the fellows start with median lobe enucleation, and they master this very quickly. I would say, 5 cases, they're pretty good at peeling up the median lobe. Detaching from the bladder neck is a little more problematic, and I always cut in from the sides to avoid a ureteral injury. And now that lobe is detached into the bladder. After I do the median lobe enucleation, I'll do what I call the apical turn. So I slightly incise the urothelium just to create a pocket, and then I will put the scope in that pocket, and then I just twist it around the apex very easily. I use low energy, 1 joule and 20 hertz to dissect any attachments at this location. I'm just proximal to the sphincter, and my laser is firing forward away from the sphincter. So it's actually more difficult to cause a sphincter injury than you think. And I carry this dissection all the way over from, in this particular case, the 10 o'clock position back across 12 o'clock over to 1 and 2 o'clock to develop that anterior plane. And this can be a very quick and simple step. Now I've developed the anterior plane, and I have the scope between the adenoma that's below me and the capsule that's above me. So what I've basically done is I've taken the scope and I've gone around the apex all the way past 12 o'clock over to the 1 and 2 o'clock position to free things up. Now, once I've created this apical turn in this space, now I do the anterior plane dissection. And this is the next step that is very common for the learners. So once they've progressed past median lobe enucleation, they'll do the anterior plane dissection. And I'm just carrying that plane from the sphincter all the way through the bladder neck. And as I get closer to the bladder neck, you can see that the tissue fibers change. So you see these up and down, what I call bailing of the prostate. And I know I'm in the correct plane because I have adenoma below me, capsule above me, and I'm going through the bladder neck fibers. So I will just cut through these bladder neck fibers. And there's often a lot of bleeding vessels near the bladder neck. It's far more vascular than you need to take care of those. So I take care of the bleeding as I go, and then I just cut through into the bladder to open up that space. And then I'll take down those bladder neck attachments at this time because they're readily exposed to me. So once I've done the anterior plane dissection, then I need to take care of that strip of urothelial mucosa that I created as I went around the apex. So I'll come back and cut that at this time just to release that urothelial mucosa. This is not early apical release. This would be considered late apical release. I like the later apical release because I feel when I do early apical release, I leave more tissue near the sphincter and apex. And so, when I'm doing a HoLEP, I'm usually doing it in patients that have failed other treatments or have very large prostates, and I want to get them as maximally de-obstructed as possible. So now I've cut the urothelial strip, and now I'm going to divide the lobes in half into a right and left half. And the reason I do this is not that I have to, but it makes it so much easier to teach learners, in my opinion. By releasing the 2 lobes, you don't have to worry about all of these other forces pulling on the lobe as you're trying to get traction, counter traction. It makes the movements extremely simple. Now, once the fellow has been here a while, I might leave the lobes attached and do a modified in-block technique. But for the most part, when I'm training, I want to divide these lobes because it keeps that traction, counter traction very simple. It's all in one plane, and it's not pulling and tenting up the capsule in other planes. I find when you leave everything attached, you're at a higher risk of perforating. And dividing the lobes is usually pretty quick. So once the lobes are divided, then I just complete the enucleation laterally and push the tissue into the fossa and then repeat it on the other side. So this is this big 300-gram prostate, and this fossa is extremely dry. And the reason it's dry is because I do a lot more lasering and a lot less peeling. By lasering, you're delivering heat energy as you work, and you don't get the bleeding that you would see otherwise. This nice large fossa, sorry. And this is one of my patients who has urothelial carcinoma, so he gets a regular cystoscopy, and this is what his fossa looks like a year after surgery. You can see that this patient is not going to have problems with BPH again. There's really nothing left to this prostatic fossa. It's a nice wide open channel, and it's really just an extension of the bladder at this point. So I've talked to you a little bit about how I do HoLEP and how I like to teach HoLEP, but what are we really looking at for outcomes? Well, when we talk about any BPH procedure, we really need to discuss measurable outcomes, such as voiding outcomes, retention rates, flow rates, quality of life, retreatment rates, and then you have to think about the complications. What are you giving up to get those results? So immediate postoperative complications, long-term complications, continence, and sexual function. So intraoperative complications that can occur with HoLEP are capsular perforation, bladder injury, fluid absorption, and ureteral orifice injury. Capsular perforations are actually really uncommon once you get moving. And this video is of one of my fellows when he was doing a case on his own. And you can see that he's perforated through the capsule in the superior portion, and he sees the fat and he realizes that he perforated. So now we're going to correct it. It's actually pretty common when you're first learning HoLEP. The nice thing is that the prostate is very forgiving. So even if you perforate, you can come back in and save it, recorrect your plane, and really not change the course of the outcome. So one series of 280 HoLEPs identified 27 perforations, and in only 3 of those perforations did they feel they needed to leave the catheter in longer than they had planned. So a perforation generally does not alter your treatment plan unless it's covering a large majority of the surface area. A bladder injury, as I stated earlier, is really the most dreaded complication, and it really doesn't happen that often. When it occurs, it's during morcellation, and most of them are superficial. If you think about it, like this is a picture of a bladder injury. This is not as deep as what you would do with a TURBT. I mean, this is more superficial. There is a little bit of fat there, a little bit of muscle exposed, but really significant injuries occur in around 0.1 to 4% of the time. Most of the time, you can just manage it with prolonged catheterization. If it occurs early during morcellation or appears to be intraperitoneal, you need to fix it, open the patient and fix it. Some people advocate morcellating in the fossa to prevent injuries. Sometimes I'll morcellate in the fossa to keep the tissue from floating away, but not to prevent the bladder injuries. Fluid absorption and ureteral injuries are also very uncommon. I was fortunate enough to be part of this case report here on fluid absorption. When you think about HoLEP, about 1/4 of patients will actually have significant fluid absorption. So one study looked at alcohol labeled saline and found that either between 200 to 1,000 cc's of fluid was absorbed during a standard HoLEP when they did breathalyzer tests on the patient. So you're actually absorbing quite a bit of fluid, and I always give Lasix at the end of the case to help prevent any significant fluid overload. If you get into a big bleeding sinus and you're taking your time, you actually can have severe hemodilution of the patient, and they can develop metabolic acidosis. If that occurs, you have a hard time extubating and the patients need more supportive care, and possibly an overnight stay in the hospital. It's not common. I've only seen it once in almost 3,000 cases, but it can occur, so you have to keep that on your differential. To date, I've not had a ureteral orifice injury, so I'm going to knock on some wood here. You think it would be more uncommon because these big median lobes lay back over the UOs, but it's just not that common. It's usually, if you keep the bladder distended and don't let it collapse, it's hard to injure the ureteral orifices with the laser. And usually if you do injure it, you just put in a stent, leave it in a week and take it out. I think bleeding is probably the most recognized complication of HoLEP, and clot retention is what we all fear. We also know about incontinence, infection, and the need for recatheterization. So clot retention and return to the OR used to be far more common than it is now with the newer high-powered laser. It occurs between 0 to 3.6%. Transfusion rates are exceptionally low, less than 2%. And I don't even check labs on my patients anymore. So they don't get a type and screen. They don't get postoperative labs. I mean, we just don't need to do that now. Really, the risk factors for continued bleeding after a HoLEP is if you don't resect enough tissue, you can leave some BPH tissue that have sinuses that are unlikely to coapt, and you get that bleeding that occurs. Or if you get too deep and you get into the venous complex that's around the prostate, that can cause significant bleeding as well. One trick is if you do have a patient who has a well-formed clot in the bladder, you can easily use the morcellator to remove that clot, and it works very efficiently and easily. So that's one trick if you ever are in that situation. Failing the voiding trial and need for recatheterization is very uncommon. Some people will fail their post-op day 1 voiding trial, but long-term failures are unusual, less than 1%. To facilitate discharge and early voiding, I actually fill patients' bladders up with saline to artificially fill them so that they will void and go home. And that seems to work very well. Infectious complications are also quite rare, around 6%, 0 to 6%, and is usually an epididymitis or a UTI. Patients who are in preoperative retention who self-intermittent catheterization or have an indwelling Foley are at higher risk. So if patients have a positive urine culture or an indwelling catheter or self-catheterize, I will give 1 week of culture-specific antibiotics pre-op and post-op. Otherwise, if they have none of those properties, I just give them the peri-op antibiotics and that's it. Long-term complications, we think about bladder neck contracture, permanent incontinence, stricture rates, erectile dysfunction, regrowth, and retrograde ejaculation. So bladder neck contractures occur about 0 to 3% of the time, and usually are seen in prostates that are less than 50 grams. And I think you see that with any procedure, whether it be HoLEP, green light, TURP. When you get into the smaller prostates, you do run the risk of a bladder neck contracture. So usually if it's a smaller gland, I will do a bladder neck incision at the 3, 6, and 9 o'clock position at the end of the case, just to spring the bladder neck open more maximally. As far as urethral strictures, that's why I have started using the smaller scope. So if it's a smaller prostate, you really don't need a 28 French scope. And I think you can do a 24 French or even a 22 if you want to limit the risk of injury to the urethra. If I am going to use a larger scope, I always make sure that I dilate the urethra up to 30 French using sequential sounds and use a significant amount of lubrication to help reduce friction. Urinary incontinence is very common immediately post-operatively. I tell my patients that they have a 30% chance of needing to wear some kind of pad right after surgery, and that resolves over days to weeks right after the procedure. In my experience, it's often urge. So they gotta go right now. They get the urge to void, they just can't make it to the bathroom. I hold off on giving any type of anticholinergics for 3 weeks because I want them to just naturally heal. But if they're still having issues at 3 weeks, then I'll give them the anticholinergics. Pure stress is actually quite rare. So if you're using a very gentle pressure when you're working at the apex, you're not going to get the bruising and strain to the sphincter muscle that you would do if you're really torquing on that scope. I do have all my patients do Kegel exercises, and I start that before surgery. I give them a handout on them, tell them to start so that they understand where the muscles are, but it's really not a stress issue. It's more of an urge issue. Erectile dysfunction, I find it interesting because I actually talked at the Texas Urologic last week, and they were asking me a lot of questions about erectile dysfunction and HoLEP. And I told them, there's been multiple studies that have demonstrated no increase in erectile dysfunction in patients before or 2 years after HoLEP. We do know that they get retrograde ejaculation, but it should not be affecting their actual erectile function. And in reality, a lot of my patients have a higher IIEF score after their HoLEP than they did before because they're sleeping better, their life is better, and their erections improve a little bit. But you do have to inform the patients that they will develop retrograde ejaculation. This is a conversation you have to have. You have to take the time to inform the patients, because they don't care when they have a catheter in, but then they get the catheter out and they go back to normal life, and it becomes a real issue for them. So we do a lot of work counseling on that. But despite these potential complications and limitations, I still think that HoLEP is not the gold standard, but the platinum standard for BPH procedures. Since 1996, there's been over 470 studies performed on HoLEP, and there's been randomized clinical control trials, comparative studies, meta-analyses, and universally, HoLEP has been found to be superior with regards to catheterization time, hospitalization time, long-term improvement in symptoms, and less bleeding. And it's been compared to TURP, green light, ThULEP, robotic simple prostatectomy, and open prostatectomy. So you can't say that there's not literature to support HoLEP's role in the treatment of BPH. One meta-analysis that I'd really like to highlight is by Zong, and it was in 2019, and they compared over 600 HoLEP patients to 600 TURP patients through multiple studies. And they found, with regards to hemoglobin loss, hospitalization time, catheterization time, stricture rate, blood transfusion rate, that HoLEP outperformed TURP across the board. When you talk about transient incontinence rate, a lot of people ask about leakage. Well, why would you do a HoLEP? Why not just do a TURP? Well, the transient incontinence rate between TURP and HoLEP is the same. So if you have a good resectionist that's going to resect a lot of tissue for a TURP, you're probably going to get that transient incontinence rate with the TURP as well. I mean, it's just part of going in and removing prostate tissue. The only area where HoLEP was not outperforming TURP was in operative time. The TURP procedures were faster than the HoLEP procedures. But I would say once a HoLEP surgeon gets well past their learning curve, they should be just as fast as a TURP, if not faster. HoLEP has also been compared to open prostatectomy, and not surprisingly, the effectiveness outcomes were all extremely similar. Long-term effect, short-term effect. Complication rates, of course, were less, but similar. But HoLEP had just a faster recovery time, shorter convalescence, less time in the hospital, less time with a catheter, quicker return to work and normal activities. HoLEP's also been compared to robotic simple prostatectomy. And I think robotic simple prostatectomy is a good procedure. I think if you can't do, if you don't have someone who is doing HoLEPs at your institution, robotic simple prostatectomy is the next reasonable option for that patient. It's better than doing 2 or 3 resume procedures or putting in 12 UroLift clips. You really want to do the right thing for the patient. I think robotic simple is a nice alternative if you're not doing HoLEP, but it doesn't give the same outcome. So when they've compared robotic simple to HoLEP, they found that there's longer catheter duration times, longer hospitalization times, and there's less tissue removed. That they can't see the plane like we can with HoLEP, so they are leaving tissue behind, and it's a longer procedure. Furthermore, you're at higher risk of developing higher grade complications, such as Clavien 3 grade complications versus that being really not heard of with HoLEP. We often use change in PSA to be a surrogate for adequate BPH treatment. And we talked a little bit about this yesterday with the cases, but after a HoLEP, your PSA should really be 1 or less. Like you should have a greater than 90% decrease from your pre-op to post-op PSA because you've removed all of the adenoma and all you have left is a thin capsule. And you don't really see that with any other procedure except open prostatectomy, where you get that massive drop in PSA. Like with a green light laser ablation, the study by Tay published in 2006 only had a 17% PSA decrease from pre-op to post-op, and most TERP series are around 70% decrease. But I think where HoLEP really shows its true benefit is this should be the last surgery for the patient. Retreatment rates have been published from anywhere from 0.1% to 4%. But this particular study that I like to highlight was one of the first randomized clinical controlled trials performed by Gilling. And they randomized patients to either HoLEP or TERP. And then they followed those patients for 7 years postoperatively. And at every time point, the AUA scores, the quality of life and the flow was better for the HoLEP group than the TERP group. Furthermore, when they did their 7-year follow-up, 3 patients in the TERP group and none in the HoLEP group had required repeat surgical intervention. So it's unlikely if you do a HoLEP on someone, they're going to need another surgery. But if that doesn't convince you, a more recent study from Saudi Arabia looked at almost 1,500 HoLEP patients, and they were followed over 18 years. And at 18 years follow-up, their PSA was still reduced by 66%. Their urethral stricture rate was 1.4%. The bladder neck contracture rate was 2%. And only 1.4% of patients needed another BPH surgery over 18 years follow-up. And the patients that had required a repeat BPH surgery had small glands. They were less than 55 grams, and they had occurred in the surgeon's learning curve. So if you get someone outside their learning curve and you have larger sized prostates, you can more confidently tell a patient that they're not going to require another surgical procedure. We talked about this as well yesterday, but HoLEP is one of the few procedures that can be utilized in the anticoagulated patient, along with green light and THULEP. And this recommendation made by the AUA is actually made off of fairly poor data. So one of the studies that this recommendation was based off of was by Bishop, and they did very small prostates, 28 grams versus 23 grams in the anticoagulated versus non-anticoagulated group, and said that the patients did great and it was safely performed. But the anticoagulated patients had an extra day in the hospital. They were more likely to fail their avoiding trial, and 7.7% required a blood transfusion. So it's not stellar results back then. But fast forward to 2021, and we looked at our outcomes using newer laser technology, so the higher powered lasers. And we actually found no difference in our anticoagulated patients versus our controls. So there was no increase in transfusion, clot evacuation, failure to pass their voiding trial, drop in hemoglobin. They actually did great. And I think that is a testament to the improvements in the laser. This over here is one of my patients that I just treated maybe a month ago. His INR is 2.9 at the time of surgery. His platelet count was 80,000. And this is the catheter at the end of the case. So, not every patient looks like that, but you definitely can get good results even if the patient is anticoagulated. And why is that? Well, I think it has a lot to do with what they've done with the bubble for the laser. So a regular Holmium laser bubble will collapse back onto the laser fiber. But with the newer pulsed modulated lasers, the bubble will actually travel forward. So you're ending up getting twice the energy delivery at twice the distance away. And this results in better hemostasis for the patient. But that's not why it was developed. In actuality, it was developed because we were complaining about how badly the fiber broke back during the surgical cases. We said, wow, if there's one thing we could change for HoLEP, that would be to get this fiber to stop breaking, because we constantly have to stop and readjust it. So Luminous developed the Moses to prevent fiber breakback. And they actually truly did do what they set out to do. When you look at prostates performed, or HoLEPs performed on prostates using a standard Holmium laser versus the pulsed modulated laser, you can see that the fiber breakback was 29 millimeters for standard Holmium laser versus 2.7 millimeters for a pulse modulated laser. So your fiber is extremely stable. It's not going to break back, and you don't have to spend time adjusting it. But there was also unforeseen consequences. So we found that when we used this new laser, we were more efficient and we were better. So when we compared HoLEPs using a standard Holmium laser, using either a 550 or 1000 micron laser fiber versus the pulse modulated laser, we found that with the pulse modulated laser, our enucleation time was faster, our laser cutting time, so the amount of time we were cutting was faster, and the amount of time we were spending gaining hemostasis after we had enucleated was decreased. In fact, we were more efficient for any size prostate. For every 10 gram increase in prostate size, we had a 40% decrease in the amount of time we needed to perform hemostasis, or a 3.9-fold decrease in hemostasis time with Moses, regardless of the size of the prostate when you compared it to standard Holmium laser. So it's efficient and faster regardless of what you're tackling. And that was the huge benefit. And why is this? Well, if you looked at this particular example where we're gaining hemostasis with the Moses fiber, it takes very little time to control the bleeder, as opposed to a standard laser fiber where we have to go back and forth between the bleeding sites because it will start bleeding again. The other thing that can happen with a standard Holmium laser fiber is when you try to gain hemostasis, you actually start digging these holes and you chase this blood vessel deep into the capsule, and it can be very difficult to get under control. But you don't see that hole digging phenomenon with the pulse modulation. It spreads the energy out so that you get a wide surface burn, and I think that's the difference. But pulse modulation is not thulium. And I want to make sure that that is clear. We have excellent hemostasis, but we're not getting charring. So on the left, you can see that we have a thulip where it's just all char and they're coring out chunks of tissue. It's hard to really see a plane. And on the right, we have a MoLEP, or pulse modulated HoLEP. And yes, there's less bleeding, but you don't get the char effect, and you can still see the tissue planes to be certain that you're doing a true enucleation. So much different. And because we're so hemostatic, we're actually able to send patients home the same day, which I think is a huge change in HoLEP. But we weren't the first people to do that. Day case for BPH resection has been around a long time. And in 2002, the first bipolar TURP as a day case was published. They looked at 40 men. They all had an ASA of 1 or 2. I can't say that I've ever operated on a patient with an ASA of 1, but in the study they found them. And they were agreeable to go home. 85% of the patients were capable of being discharged on postoperative day 0. 6 had to be admitted for pain control and nausea and chills. And they had their trial avoiding on post-op day 2, and 72% of the patients that were surveyed said that they felt it was fine to go home, and they felt it was acceptable that they were treated as an outpatient. So this parlayed us into trying to do HoLEP as an outpatient or same-day discharge. And one of the first studies was published in 2020, and it came out of Mayo, Arizona, and they looked at 179 patients who underwent HoLEP. They only identified 26%, or 47 patients, who they thought were candidate for same-day discharge. And to be a candidate for same-day discharge, you had to have an ASA score of less than 3, a prostate volume less than 200, be under the age of 75 years, and the surgery had to end before 1 p.m. with very minimal hemoglobin drop. However, despite having these strict criteria, only 59% were successfully discharged on the same day. The others could not be discharged mainly for hematuria or anxiety. And when they discharged the patient, 28% bounced back to the ER, with 62% of those patients requiring readmission. So in my opinion, this is a complete and total failure. You can't have 28% of your patients coming back to the ER, and you can't reliably say you're going to send someone home if only 60% of the time you're able to discharge. But remember, this is with using older laser technology. Now, fast forward to the newer laser technology, and we're routinely sending people home the same day. So this is a study where we looked at same-day discharge in this column and compared to overnight admission. And we found that the big game changer really was the newer laser technology. That's what allowed us to send the patients home. It also made us faster. It was a faster surgery, so the patient was under anesthesia less time. And we had no increase in complications. But what was interesting is that patients were more likely to do better if they went home. They were more likely to pass their voiding trial than if they sat in the hospital overnight, in bed, not walking, and not going back to normal activities. So it actually improved patients' outcomes by sending them home the same day. But we decided, if they're not bleeding that much, why not just take their catheter out before they leave? So this is the pilot study of 42 patients where we said, let's remove their catheter and see if they can urinate the same day. These are big prostates, 96 grams enucleated was the mean size. And so we didn't pick just smaller prostates. And we found that over 90% of the time we were successful at removing the catheter. We had 4 failures. And when we went back, this is one of the failures. So this is a person whose catheter was removed. He couldn't urinate. We put the catheter back in. And you can see that he didn't fail because he was in clot retention. He failed for other reasons. And so we went back and we looked at our protocol and we tried to minimize things that would cause the bladder to not work as well postoperatively. And we come up with a very good protocol for this. So in my experience, based on the research I've done, the newer laser has resulted in a significant improvement in several areas. The mean length of stay now for my HoLEP patients is 2.6 hours. Over 80% can be discharged the same day with very low return to the emergency room. So if we do a 90-day ER return rate, it's around 12% for our patients. The mean catheterization time is around 5 hours. And we have similar success rates that have been shown in very large prostates over 175 grams. So it's not just small prostates, it's large prostates as well. And if you compare these results to other BPH procedures, you can see that we actually do very well compared to office-based surgeries, the missed surgeries. So if you look at UroLift, for example, most of this is done as an outpatient. But the catheterization time is around 1 day, which is exactly where we are with HoLEP. If you look at Resume, you have 90% have a catheter placed post-procedure, and the catheterization time can be anywhere from 3 days up to a week. Aquablation also has a catheterization time measured in days, usually around 4 days. And prostatic artery embolization does not generally require a catheter, but if patients are in urinary retention at the time of the procedure, their catheter is left in 2 to 3 weeks. And they do have higher rates of acute retention with PAE, around 4%, and they will require a catheter for a week too. So HoLEP is actually outperforming these other procedures with regards to catheterization time. So how do I do my same-day discharge? So intraoperatively, it's very important to communicate with the anesthesia team. I want to avoid intraoperative use of narcotics and muscle relaxants. So most of the patients have an LMA or an iGel, and they breathe on their own. I do laser dissection. I do not do blunt dissection. I think if you use the laser to dissect as opposed to peeling, you have much improved hemostasis. I coagulate the bleeding vessels in real time, and then I perform aggressive hemostasis of the prostate before and after morcellation. And this is just a video of me using laser to dissect and then doing aggressive hemostasis before morcellation. And then post-operatively, again, PACU, avoid narcotics. Ketorolac is safe. All my patients get Toradol if they have adequate renal function and do not have an allergy. And we use that for their pain control. And the patients have to get up and ambulate. So I want my patients walking within 1 to 2 hours of the surgical procedure to get them up and moving and recovering faster. In the PACU, we do run 1 3-liter bag of CBI while they're recovering. And then we check on the patient. If the hematuria is minimal, we do a fill and pull trial and check their PVR, and they go home. If the hematuria is persistent, though, we run a second bag, and if it's still red, then we just keep them overnight. There's no reason to push it if it's not drying up. These improvements have actually helped me in the COVID era because our goals changed as a country and as a healthcare system. We wanted to avoid hospitalization. We wanted to avoid admitting patients to the hospital. And I could tell my hospital that I routinely can discharge patients home the same day. So they allowed me to treat patients in retention during the lockdown. We can do the procedure with an LMA or spinal, so it did decrease the respiratory risk. And I actually did HoLEPs on several COVID patients. We had a large COVID population in Indiana, and we had quite a few prostatic abscesses in these patients. I'm not quite sure what the correlation is, but I did more than a handful of these abscess enucleations, and they did great. We did it under spinal. There was no bleeding. We had no sepsis rates, and they were able to get their catheter out the next day. Sending the patients home has also resulted in improved cost savings. So we looked at how much the HoLEP procedure costs using newer laser technology versus older laser technology. And we factored in the fact that the newer laser technology is more expensive, the fibers are more expensive, and we looked at every single charge that the patient would receive during their surgical procedure. And we found that with the newer laser technology, patients were more likely to go home, and we had no difference in readmission rates. They were likely to bounce back to the ER, but they were not at an increased risk of being readmitted. And if we look at just the costs in general, using the newer laser, we found that we saved $840 per case. If we went ahead and factored in the 90-day readmission rates, it was still $747 per case saved by doing it this way. And to remind you, this is all done in the hospital setting. If you translated this to a surgery center, you would find even greater savings by doing it that way. So it definitely helps the healthcare system.
Dr. Krambeck, one quick question about that. Sorry to interrupt. So how much of the benefit you think is attributed to the laser itself versus the new pathway? That because it seems like there was more than one intervention. So it's Toradol, the early fill and pull. The data you showed about a lot of the data that was shown about HoLEP and its benefit over TURP was done presumably with an older laser fiber. One of the challenges we've had here is just the high capital cost of the Moses laser, high fiber costs, and I wonder if we could achieve the great benefits you're showing just by using the old laser fiber with a different pathway.
Yeah, so the pathway I showed is how you get your catheter out the same day. You don't need to do those things if you're just going to send them out with a catheter. And sending them out with a catheter doesn't increase your cost because you're not billing for the decath. So that pathway is just to get your catheter out the same day. I could not send patients home the same day without this laser. We've had days where the 2.0 was broken for some reason. Every single patient stayed because they're not dry enough. You don't get the hemostasis that you need to send these larger prostates home the same day with the older laser. I mean, I think the data would look more like the Humphreys study, where about 50% of the time you can send them home, because Humphreys is an excellent surgeon. He does a great job, but that was using older laser technology, and you just can't reliably stop the bleeding enough to send the patients home. So you need the newer laser. I can't tell you exactly what the magic is, except that you have significantly less bleeding, and you can see it within the first 2 cases that there's a huge benefit to it. I mean, I would love to say it's all me in my pathway, but it's not. It's the laser. It's not me. I would have to say that the biggest criticism, and we discussed this yesterday, is the lack of hands-on training, the steep learning curve, and a difficulty in learning HoLEP. And, there's been a lot of studies on how do you learn HoLEP. And one of the earlier studies said it takes 20 cases for an experienced surgeon who's fully supervised. A lot of my fellows are very good, but I can't tell you that most of them have it in 20 cases. And they say 50 cases for an inexperienced surgeon. But I really think it's closer to 100 cases before you feel really comfortable and like you can tackle the bigger prostates. And so when you're starting out, I would recommend this as your starting point. So focus on the prostates that are 80 to 110 grams. The smaller prostates, I think it's harder. So I think it's very difficult to find the plane when you get under 70 grams in the smaller prostates. So smaller prostates are probably more difficult than the larger ones. And if you get above 110, it's easy to get lost. You get lost in the adenoma, you're going to spend too much time. So 80 to 110 is the sweet spot. You want to look for patients who have a normal BMI, and you want to limit bleeding. So in order to limit bleeding, don't operate on patients who have a chronic catheter or who have chronic prostatitis or infections. Those patients bleed more. And you really want to be doing 1 to 2 cases a week. You have to have people referring you cases, and you have to stay focused. You don't want to reinvent the wheel every month when you do your 1 case. You want to be doing it every single week. So you need that support. And then when you're picking your cases, pick wisely. So this is a particular patient. This is actually the video I showed. This is that 336 gram prostate. So big, large, median lobe. And you would think, wow, this is a really difficult case. And then this is a 230 gram prostate. So not as big. You would think, wow, this would be easier. But in reality, the bigger prostate is an easier prostate to do a HoLEP on, because all of the tissue is already in the bladder. It's all projecting into the bladder. You just have to detach it. Whereas the other prostate, it's tucked up under the trigone. So this requires significant skill to go back and enucleate this that's tucked up under the trigone. And so think about that. Choose median lobes. That's an easy place to start. So the take home is appropriate case selection, 80 to 110. Avoid anticoagulation, chronic catheterization, prostatitis. Watch people, go in person, watch videos, and get support from your department. So in conclusion, HoLEP produces results similar to simple prostatectomy with fewer short-term and long-term morbidity. The retreatment rate is low at 18 years follow-up, and the newer laser technology, I think, allows us to get that hemostasis to a point where we can send the patients home and shorten the learning curve. So thank you very much for your time, and I'll take any questions you might have.
Amy, that was a great review of HoLEP. I do have a few questions for you. One is, say someone comes in and they have this massively distended bladder, like a 2-liter bladder. Do you think there's a role for urodynamics? Because I have read that you're so thorough removing so much tissue that even if they don't show great detrusor function with urodynamics, they might still be able to urinate. So what are your thoughts about getting urodynamics on a patient like that?
Yes, so we actually did this study when I was at Mayo, because I kept getting these patients referred to me who already had urodynamics done, and it would say acontractile bladder, and I would go ahead and do the HoLEP and they'd urinate. So we took a group of men who had acontractile bladders, we did HoLEPs, and then we repeated the UDS at 6 months post-op. And about 60% of the men actually regained some function of their bladder. So it wasn't the best squeeze, but they did have some detrusor function. And the rest of the men were able to just void by Valsalva. So they would bear down and empty their bladder. So I stopped doing UDS on patients who are in retention. The only time I do UDS is if a patient has bad urge incontinence before surgery. And this way I can assess their bladder capacity. We can talk about anticholinergics or even third line, treatments such as Botox and InterStim, which may be necessary after surgery. But I don't do it for retention.
And then another question for you. It sounds like you like to use mostly laser energy to free up the prostate and enucleate it. Do you think that patients are going to have more irritative symptoms? Is there a correlation with how much laser energy you end up using, and then how many symptoms they have afterwards versus trying to peel more, even though they're going to bleed more, but maybe their post-op course will be less eventful?
Yeah, so that was one concern I had, especially switching to this newer laser where you have better energy delivery. But we've had no increase in dysuria. We've had no increase in incontinence. If anything, the incontinence rates have gone down. So I was concerned about that as well, but there's been no correlation whatsoever.
Okay, I just have one more question. I don't mean to hog the floor here, but when you take the catheter out the same day, I mean, you're measuring your success that you've got, your endpoint is you got them home without a catheter. But I mean, do you look at quality of life? I mean, is their satisfaction better that they got the catheter out? Because I'm imagining these people are home without a catheter, but they're urinating every 2 seconds and they're really uncomfortable. And maybe a catheter gives them a little bit of rest.
No, actually, that's not been our experience at all. So I know that Peter Gilling said that he has tried to take the catheter out and the patients are miserable, but we really have not had that experience. So I've had several of the patients say, going to the dentist is a worse experience than having this procedure done because they walk out without a catheter. Like, we don't want people bouncing back to the ER. I've been here since January, and next week we'll do our 200th case. And we've had 2 people bounce back to the ER. And one of them was voiding, and he just was very stressed, and we did a PVR, he looked good, and he went back home. And the other patient was in clot retention. So I think that's pretty good numbers given the volume that we're doing on a daily basis. We're just very careful. We don't want the patients coming back to the ER. We want them to feel comfortable, and we want them to be happy with their outcome. So if they're at all nervous or anxious, they spend the night. If they're not happy with their voiding, they spend the night.
Okay. Are there any other questions at all?
Yeah, Harris Foster here. Great talk. Actually, Dan stole my question about the urodynamics, because that's interesting. If patients can, in that minority of patients who still have problems with their bladder contraction afterwards, and they can void by straining, by Valsalva, doesn't that almost by definition mean that they would have stress incontinence, right? I mean, if you now maybe they have to generate significant pressures or straining to void, but you wonder if the fact that they can even, because most people can't void by straining, or at least most men. Were there any increased rates of incontinence in those patients?
Yeah, that's a great question, but in reality, these patients are less likely to have that temporary post-op incontinence. So we haven't seen an increase in long-term incontinence. I think, the post-op incontinence is more irritative, and these guys just don't get the irritative voiding symptoms. And then long-term, we just haven't seen the increase in stress incontinence. And I don't know, I mean, if they're having a bowel movement the same way, I think they still have to relax their pelvic floor to urinate. But we just haven't seen it. In reality, I actually counsel these patients that they're less likely to have incontinence because they don't have those irritative components to it.
And actually one other question. And that has to do with, this is sort of a resident training thing. What are your thoughts about, the skills needed to do a TURP? Oftentimes are translated into doing big TURBTs and, sort of getting out of trouble if somebody's bleeding, et cetera. As you do more HoLEPs for BPH, what are your thoughts about the reduction in the teaching the residents endoscopic skills vis-a-vis, using the resectoscope, et cetera?
Yeah, so I mean, the residents use a resectoscope quite often for bladder tumors, so they're very adept at that. So I don't think there's any issues learning that. As far as getting out of bleeding, they can always use the laser to do that. They can do an enucleation
Gotcha.
if they have bleeding prostate. I feel like the residents get an excellent all-around training, so they're learning multiple modalities that they can use endoscopically to augment their practice. So I feel like it only just adds to their training. I've heard that argument that the residents aren't learning how to do TURPs, but I should have put the study in the slide deck, but there was a study where they looked at the number of cases it takes to master a procedure. So the only difference between a TURP and HoLEP is that you can do not a very good TURP and still get out of the case, but you really can't do a not very good HoLEP and get out of the case. There's only one way to do a HoLEP, but you can partially resect a little bit with a TURP and get out of the case and be fine. But when they use strict parameters on percentage of tissue resected, amount of time it took to resect that tissue, and bleeding outcomes, it took longer to master a TURP and do a TURP well than it did to master a HoLEP and do a HoLEP well. So I think there's a little bit of a misnomer. I mean, TURP resectionists, they're really good surgeons. Like, they have to do quite a few TURPs to get very good at it, to be a good TURP surgeon. And I think we forget that point of that.
Thanks.
Okay, do we have any other questions?
Go ahead, Dr. Collins.
Okay.
Oh, I just had a question, Dr. Krambeck. Thank you for the excellent talk. Do you have any particular tips or tricks on how to proactively or reactively manage the patients who have significant irritative symptoms after their HoLEP? We send all of them home with a couple of days of peridium, but are there any other tricks that you have?
Yeah, so if they're in that 12% of patients who have the dysuria and pain with urination, it's usually a younger patient, right? It's very uncommon to see that with the older patients, but I give them diclofenac just like I would a stone patient. And if that doesn't work, then we bump up to a Medrol dose pack, and that will take care of it. But it's just very uncommon to have to escalate. But normally I would start with diclofenac, or I just give them diclofenac because it's a prescription and there's some psychological benefit to that. But ibuprofen is just as effective.
How soon would you start ibuprofen after these surgeries?
I would start it the night of. Yeah, they can I give them Toradol in the hospital, and then when they leave, they can start ibuprofen or diclofenac. And I do that for the younger patients. The older patients, I don't. I would let them call me and let me know if they're having burning or problems. But if they're in their 50s, I go ahead and give them the prescription for diclofenac because they're more likely to have issues.
Okay, do we have any other questions for Dr. Krambeck? All right, well, it's 8:30, so we'll let Dr. Krambeck get back to Chicago. So,
All right.
Thank you so much for a wonderful visiting professorship. There is some Yale swag en route to you. Hopefully, I think it will arrive this week. But thank you again for such a wonderful 2 days. We really appreciate you.
Well, thank you so much for having me, and maybe someday we'll meet everyone in person. And it was just a great experience to interact with everyone. So thank you very much.
okay, thank you so much. Have a great weekend.
Thank you.
Bye-bye.